Hello, everyone. Thanks to the organizing committee for the kind invitation. I'm Winnie CHU from the Chinese University of Hong Kong. My topic today is MR imaging and etiopathogenesis of AIS. AIS is a multifactorial disorder with many suggested etiologies as shown here. Our institution performed MRI whole spine in all pre-op AIS patients as part of the standard care. So I have a chance to look into the neural factor in AIS. One of the neural theories about etiopathogenesis of AIS is the disproportional neuroosseous growth, in which the longitudinal growth of the spinal cord fails to keep in place with the growth of the vertebral column. As a result, a relative tether is created by a short spinal cord leading to formation of scoliosis. One of our early studies on MRI spine of AIS showed that the anterior vertebral body height was significantly greater than the posterior vertebral body height, and this ratio was positively related to corpse angle, hence suggesting an anterior spinal overgrowth in AIS. At a later study, the findings was reaffirmed by 3D CT performed in pre-op AIS. Furthermore, in the studies, the intervertebral discs are found to contribute most to the anterior spinal overgrowth when compared with the vertebrae. In another MR study, we make use of the multiplanar reformat technique. The center line or midpoint of each vertebra was manually traced, and the length of the vertebral column were measured from the tip of C2 down to the inferior end plate of L5 as shown here. Similarly, the length of the spinal cord was also measured from the tip of C2 down to the conus medullaris. In this and subsequent system studies, comparison is made with age and sex match controlled, and all AIS subjects are girls with typical right thoracic curve. We find that AIS has significantly increased segmental length of the thoracic spine, but not the cord, hence resulting in a reduced cord to vertebral column length ratio. 28% of AIS was also found to have abnormal somatosensory effective potential, SSEP. For instance, SSEP is a test to evaluate the function of the dorsal column of spinal cord. How is it done is to stimulate the posterior tibial behind the medial malleolus, and the cortical responses are recorded over the contralateral sensory foot area on the midline of the scalp. Another study, measurement was made at the apex of the scoliosis curve. We looked at the cord shape by measuring the AP over TS diameter ratio. We also assessed the relative position of the cord by the lateral cord space, as shown here. What we found is that in normal subjects, the cord is more oval, while in AIS, the cord is more roundish in shape, hence higher AP over TS ratio. In normal controlled, the cord is more or less at the center of the spinal canal, hence the lateral cord space LCS ratios is 1. While in AIS, the cord is more deviated towards the concavity of the scoliotic curve, hence the LCS ratio is much higher. We also found that the above two ratios are negatively correlated with cord to vertebral column length ratios. Chiari malformation is most common neural axis abnormality found in scoliosis children. In Darwin's study, the incidence is up to 10.3%. By definition, we should not name these children with Chiari malformation as idiopathic scoliosis. Therefore, we try to redefine the MRI reference level of cerebellar tonsils for AIS by drawing a line between the two bony landmarks, the basion B and the orbicifidus O, and remeasure the cerebellar tonsil level from this BO line. We found that the tonsil levels in normal control on average is 2.8 mm above the BO line, while almost 18% of AIS has cerebellar tonsil below the BO line as shown here. In another study, we found that the incidence of low-set cerebellar tonsils and also abnormal SSEP are fairly high in AIS when compared with controls. Now, we start to think whether a low-lying cerebellar tonsil level is related to a relative short cord, and if so, the effect should be exaggerated when the patient is put in an upright position. So we did another study as shown here. What we found is that AIS patients have more tonsillar descent than normal control. This tonsillar descent is more prevalent in upright position in up to 48% of subjects than in the supine position, where only 28% of subjects was found to have low-lying tonsil. AIS patients also have a more pronounced tonsillar excursion between supine and upright position when compared to the controls. Here is a summary of our findings. First, we find a relative anterior overgrowth of the spine, and then there is a no corresponding cord lengthening, so resulting in relative cord tethering or shortening. And this functional tethering of the spinal cord lead to a low-lying tonsil as well as deviation of the cord to the concavity as well as change in cord shape. And all these probably can lead to the abnormal somatosensory potential SSEP that we have seen. So our next question is, will these changes affect the progressions of the curve? So we perform a longitudinal study on AIS girls before they start raising treatment and follow them up to the skeletal maturity, or at least 2 years before surgical intervention. Here we have a total of 81 AIS girls included in the study. 57% shows no progression. 23% have progressions with more than 6 degrees increase in corpse angle between 2 consecutive visits, and 20% had marked progressions requiring surgery. In a regression model, the following MR features, including the reduced cord to vertebral length ratio, the increased LCS ratio, and increased AP over TS cord ratios, are found to be significant independent predictor of AIS curve progression. We then perform a diffusion tensor imaging, which is also called tractography, to look at the function of the fiber tracts within the spinal cord. There is a quantitative measurement of fractional anisotrophy, or FA value of the spinal cord, which reflect the connectivity of the fiber tract. The F8 value range from 0, which when there is a random diffusion of molecules, to a maximum value of 1 when there is a strong unidirection of water molecules. In this DTI study of AIS, significantly reduced F8 value was found in the medulla and also multiple cervical segments of the cord. But there is no significant difference found in the thoracic or lumbar levels. The findings suggest that there might be disturbed white matter integrity within the brainstem and spinal cord, leading to, together with observation of low-lying cerebral tonsils, again supporting our observation of subclinical cord tethering. So here, I summarize our research finding here in yellow. So all these structural changes might explain the abnormal somatosensory function and also postural instability in AIS, which we have reported before in our previous study. And these observed change might contribute to the initiation and progressions of idiopathic scoliosis. And we have recorded all these findings and in a review called Asynchronous Neuroosseous Growth in AIS and MRI-based research. So thank you very much for your attention.